Hi, this is Beverly Klipfer recording a lecture for Chapter 13, which deals with cardiovascular disorders. So as we know, this is really familiar to all of you guys. We understand through our practice that we see a lot of cardiovascular disease that runs in families. We also know that the large percentage of our population are diagnosed with coronary vascular disease or coronary artery disease, as many of us know it by. And statistics show us that about 1 in 3 are affected by this particular disorder. But we also know that with cardiovascular disease, it's not just genetic, that there are a complex amount of multifactorial things that can go along with cardiovascular disease. We know that the development of atherosclerosis is related to lifestyle as well as perhaps a genetic predisposition to the development of atherosclerosis. So it's not one of those diseases that we can say are entirely genetic. What we can say is that it runs in families, and people who have a strong family history are at higher risk for development of coronary artery disease. So the first thing we're going to talk about is we're going to talk about atherosclerosis or coronary artery disease. For many of you, this is just a review. We know its cause is this development of plaques inside arteries. And we know that it's not only our coronary arteries that can develop these fatty plaques. And then along those fatty plaques, we know that we get clumps of red blood cells that create clots or plaques. And the issue comes when we have decreased circulation as a result of narrowing of these arteries, or we have a rupture or release of the plaque or clot that then fully compromises circulation for that artery. There are multiple genes that have been found to be associated with atherosclerosis, and some of it has to do with inflammation. And about 50% of the people who develop atherosclerosis or coronary artery disease do have a family history of this. We know that we've talked about Apolipoprotein E or apoE. And this is, they found, is a component of our very, very low density lipoproteins. These are our VLDLs that we test for in our lipid screening. And what this tells us is that if people have this particular allele in their testing, they will tend to have elevated levels of low density lipoproteins. So they're at higher risk for having higher numbers. We know that there have been some genome-wide association studies. So what that means is that they're looking at the entire genome in these studies. And in doing so, they're trying to isolate a specific chromosome and a specific area within that chromosome. And so what they found, as our slide tells us, is that they've learned that there's a correlation on our 9th chromosome on the P arm at about the section 21 of that. And with some changes within that chromosome, we see that these people are at higher risk for the development of coronary artery disease. They did some studies where they removed that region of the 9th chromosome. And in doing so, they noted in mice that there was a change in the growth of the cells in the heart. However, with multiple studies, we can see that there is not a clear indication as to whether or not this increases a particular risk for myocardial infarction by doing so. This does not come as a surprise to anybody, but the environment also contributes to the development of coronary artery disease. We've been telling patients for a long time that we have to look at their lifestyle and in terms of development of fatty plaques and the development of coronary artery disease. So when we look at this, we consider both the family history, but we also look at lifestyle. No surprise that people who smoke have an increased risk of development of coronary artery disease. Interestingly enough, survey studies are beginning to understand that there is a relationship to how much a person smokes and how long a person smokes as to the amount of risk that they incur. Nicotine dependence, we know, is also, because we're looking at addiction and dependence in terms of genetics, that there are also more there can be a genetic predisposition to development of smoking, but we also know environmental and sociological things can impact nicotine starting and nicotine dependence and the continuation of smoking. But we do know that there are some people, and through studies, that have a mutation that is on their nicotine receptors that put them at higher risk. If they were to start smoking, that they would be addicted to the nicotine, and it would be more challenging for those individuals to stop smoking because of this change in their nicotine receptor. So we know that there are some single gene disorders that are caused that put people at higher risk. There's Tangier disease, familial hyperlipidemia, and familial alpha-protein A1 deficiency. So if we look at these, we see that Tangier's disease is what we call autosomal codominant, which means that if you just have one copy, you'll have some aspect of the disease. But if you have both dominant copies, it actually creates a higher disease presentation. We have familial hyperlipidemia, that's autosomal recessive, and the A1 deficiency is also recessive. The big thing I want to talk about here is familial hypercholesterolemia. So there is an article in your unit under these chapters that talk about familial hypercholesterolemia, and it's a very interesting article. So if you have time to read it, I think it would be helpful. The one thing we need to know about familial hypercholesterolemia is, one, its pattern of inheritance. It is autosomal dominant. So when it is passed on, a person only needs to receive one copy in order to display the trait. However, there are people who are what we call homozygous, which means that they carry both dominant alleles. And so the difference is that when you only have one of the alleles, your cholesterol levels are high, and you can use medications and these people will need medication to bring their cholesterol levels down, because genetically they just are going to have a harder time excreting cholesterol. They'll make their own cholesterol, and so they are typically going to have these higher numbers. And medication can be very effective for them, and this will be a lifelong medication. As you know, some people with high cholesterol and triglycerides, if they do some changes in their diet, lose some weight, they can see that those numbers will drop because they've made some healthy lifestyle changes. For these people, the lifestyle changes will not greatly impact their cholesterol levels, so they're going to require medication. However, there are a group of individuals who have both dominant alleles. Unfortunately for these people, they will have cholesterol levels that are off the charts. So they'll be super high, and medication is not going to be effective, or lifestyle changes. It will help. I'm going to tell you, don't discount it or say they don't need to take it or don't need to make these changes, but it's not going to bring their cholesterol level down. For these individuals, they actually require pheresis to remove the excess cholesterol in their blood system. And so there are LDL receptor proteins, and this is how they're classified, okay? This is just information for you only to understand the difference in what happens in the different classes. So how do we manage coronary artery disease? Some of this is relearning for you. Diet always is helpful. Lean meats, high vegetables, limit cholesterol foods, decrease your saturated fats. We also can put them on medications such as bile acid absorbing resins. These absorb the cholesterol in the gut so that it doesn't get into the bloodstream. Questran is one particular medication. We can put them on reductase inhibitors. We can put them on cholesterol absorption. And like I said, for those with homozygous familial hypercholesterolemia, they actually are going to need LDL apheresis. So next we're going to look at a common medical problem, and that's stroke. What we know about stroke is that they can run in families. We do know that in a family that has a history of strokes within it, it does increase the risk of other family members to the development of a stroke. We also know that it is not and rarely is seen as a single gene disorder. We know that there are two types of strokes. We have the ischemic stroke or the hemorrhagic stroke. Each are caused by different pathophysiologic process. And there's no specific genotype that has been found within just stroke presentation, stroke symptoms, stroke manifestations. And because of that, because it is not a clear-cut issue, genetic research into the particular genetic contribution of stroke is very challenging for scientists and medical professionals. There are at times a monogenic cause of stroke. However, this is a very small percentage of strokes which can be connected back to a single gene change. We do know that there are some autosomal dominant arterial pathways that can cause infarction and encephalopathy. We know people who have Fabry disease are at higher risk for stroke. And we do know that sometimes people who develop mitochondrial encephalomyopathy or perhaps lactic acidosis may have a stroke-like episodes. So one thing we want to talk about is this factor V Leiden. This is a thrombophilia. So what happens is that people clot more readily. They have a hypercoagulation process that goes on, and this results from a protein that particularly cannot be degraded by this activated protein C. So as we talked about in the last group of content that we read, that proteins are made, so there's a change or a malfunction in the protein that normally would help with anticoagulation. Okay. We know that this can be heterozygous or homozygote. Okay. We know that if you carry one copy of this particular issue, then you are going to be at risk for blood clots. And then if you're homozygote, which means you have both, we've learned that that actually increases the risk even more. And this then, if you think about it, would put people at greater risk for a stroke if they clot more easily in their arterial system. And so we talk about perhaps how does this apply to medicine. So you need to think about things that medications perhaps a person would take that increase their risk of developing blood clots just if they had a normal body system. So women taking birth control pills, perhaps that might not be the appropriate form of birth control for them because they're already placed at higher risk for developing blood clots or pulmonary emboli or perhaps a stroke related to the hormonal replacement changes that they're doing themselves. But if they have factor V Leiden, they're even at greater risk. So we need to talk about how would that affect their particular choice of family planning. We know that stroke is multifactorial. There's no one particular thing we can attribute to the cause of a stroke. We know that there are multiple genes that place people at risk for coronary artery disease that may also place people at risk for development of stroke. And in some ways, I guess that would probably make sense since we know that coronary artery disease is the result of the development of atherosclerosis of the coronary arteries. However, atherosclerosis is not selective to just the coronary arteries. Atherosclerotic development can happen in any arterial system within your body. We do know that people are at greater risk if they carry the Apolipoprotein E allele, but we also know that people who develop hypertension or have untreated or uncontrolled hypertension are also more at risk for development of a stroke. So that leads us into talking about hypertension. This book says that hypertension is defined as a systolic blood pressure greater or equal to 140, and that's in a person who's not on any medication. There are some new studies out there and some new guidelines that are looking at 120, but for now we're going to go with the current information in your book. However, I do recognize that there's some new data out there and there are some new guidelines for treating blood pressure. It also defines hypertension in terms of the diastolic pressure, which would be not equal to or greater than 90, and that again is without any medication treatment. We know that often we want to treat people who have hypertension. We want to get them either some lifestyle changes to see if that impacts their hypertension. We want to get them on medication because we know the longer they go above these numbers, the greater risk for more than just a stroke happens within the body. There are our peripheral vascular, is affected by hypertension. The workload on our heart is affected by hypertension. So we want to address hypertension as soon as we know that it's happening. We also want to not just jump the gun with one particular reading that happens to be over this amount. So often you'll have people come back for blood pressure checks if it's a new development to see if they have high blood pressure. Many primary care providers might also ask people to take their blood pressure out in their everyday life to see what it is. Then, often because we know that's coming to the physician's office or the hospital, the emergency room, minor care clinics, those particular things create anxiety and stress. And we know that those two things impacted with illness, pain, and other things can raise our blood pressure for a transient amount of time. So we want to make sure that it is truly a hypertensive situation. So as we learned in nursing school, there are two particular types of hypertension. We categorize them as primary and secondary. And most people in the population have primary. And what we know about that is that it's not connected to one particular cause. We can't pinpoint the exact reason. And often, sometimes the secondary is related to another disorder. One thing we want to think about is epistasis, which is nose bleeding, and we know that there's a gene-to-gene interaction, and so if It can modify the expression. It can either increase it or decrease it. We also know that there are gene to environment interactions. So what we mean by monogenic, which would be a single cause, and we look at the renin-angiotensin pathway. So people who have issues with renin-angiotensin, we want to know this because it can help direct how we would provide medical or medicine management for them. And then there are multiple issues, multiple causes with this renin-angiotensin pathway. And we know that there are certain genes that if a person carries, they may not respond to the low salt diet. So putting them on it would not make any difference for them, not because they weren't following the diet or not because they were not compliant, but genetically it's just not going to have any effect on them. And we also know with hypertension, there are multiple genes that work together. So now we're going to talk about arrhythmias. Arrhythmias is an abnormal heart rhythm. And we have found that most arrhythmias deal with what they call channelopathies. And so channelopathies are changes within specific ion channels that work on the electrical component of our heart. So we know that it requires both an electrical component and a mechanical component to create a heartbeat, but it's the electrical component that stimulates the muscle to contract. And so there are variations in how genes are coded for that are the proteins that deal with specific ion channels. We know that there's a sodium channel, and we can see that changes in the sodium channel can cause problems in AV conduction, can be what we call sick sinus syndrome, and this would be congenital. That means you're born with it. And with people who have long QT syndrome. So we're going to talk about atrial fibrillation. I'm going to anticipate that most of you know what atrial fibrillation. If we look at the general population, this would be the most common arrhythmia that is seen. We do know that there is a genetic link to your family history, so it runs in families. So, however, what we know is that there are multiple genes that cause this development of atrial fibrillation. But we also know that it can be acquired from other disease processes that happen. Myocardial infarction, changes to the conduction system or the quality of your cardiac muscle through which the electrical impulse must go through in order to create your mechanical and electrical component. They are learning that there are some single gene causes in a few people, but those are rare. And they are believing that this is a multifactorial issue, that it's not just related genetically, but there are outside causes that play a role in people who have a genetic predisposition to this particular dysrhythmia. One I want to talk about is long QT syndrome. So this has to do with repolarization. So there's a delay that occurs in the repolarization. And so then there's a longer time that occurs in that QT interval. And so, and we learned back in nursing school, and some of you may work in cardiology right now or on telemetry floors or in ICU, that when we have that repolarization time, that's when the cardiac muscle is very vulnerable to being stimulated. So this can create ventricular tachycardias, and people with long QT syndrome are more at risk to develop torsades de pointes. And as you can see on the picture below is a picture of an electrocardiograph reading that shows the longer than normal QT interval. And just to the side of that is what torsades de pointes would look like. And as you can tell, it looks differently than ventricular tachycardia, and it's treated differently. So these are the different genes that cause long QT syndrome. And it's important when you diagnose someone and have genetic testing that they actually pinpoint the exact gene that's causing it. Because it goes to which channel. We look at 1 and 2, that's related to the potassium channel. And we know that 3 is related to the sodium. Okay? And treatment and causes and severity is related to understanding the exact gene that's causing the long QT syndrome. So there are triggers. So if you have type 1, exercise, and especially swimming. Now don't exactly, if I had to tell you exactly why swimming does this, but it doesn't. And it also says in our book that you can have sudden loud sounds can also trigger this. And so it can trigger serious dysrhythmias, sometimes for type 2 auditory stimuli, and type 3, even at rest, they can develop this. It is congenital, so it does run in families. So we know that there's an autosomal dominant particular disorder and one that is recessive. But the one that's recessive tends to accompany individuals who also experience deafness. And you can acquire long QT syndromes, and we know that from pharmacology because we know that there are certain medications that cause a lengthening in the QT interval, and it's one of the things that we monitor on those patients who are taking those medications. We're now going to look at cardiomyopathy. Cardiomyopathy are enlarged, weakened heart muscles. As a result, the heart can no longer pump at the efficacy that it needs to in order to provide adequate blood flow and circulation to the body. We can develop cardiomyopathy. It can be genetic, but it can also be environmental. You can acquire it from many substance abuse uses. You can get it from a viral infection. Pregnancy sometimes can bring on a cardiomyopathy, and we often see patients with end-stage kidney disease, but we also see it sometimes with patients with end-stage congestive heart failure. There is familial hypertrophic cardiomyopathy. So we know that the heart muscle is asymmetrically thick. Okay, so we have a diastolic dysfunction. It is autosomal dominant. And with this thickening, we see problems with filling in the ventricles, and this creates a change in the diastolic function of our heart. There sometimes is a left ventricular outflow obstruction that occurs, and there is sometimes enlargement of the septum and changes in the movement of the mitral valve. People may be asymptomatic with this, so they may not even know they have it until they've reached perhaps adolescence or puberty, or perhaps even later in life. This table is in your book. It talks about the different genetic diseases that cause cardiomyopathy. Some of them we've seen or talked about in our other chapters, and it's just for you to read and understand. This is just a picture of, first we see a normal heart, we see a dilated cardiomyopathy, which means we have enlargement of the chambers. We have a hypertrophic, which we see enlargement of the muscle. And then there's restrictive cardiomyopathy, which is a change in the movement or restriction of the muscle. So this, you can get genetic testing. It can be diagnosed at any age. It does tell us that misdiagnosis can occur, especially in younger people, because you wouldn't think cardiomyopathy. We do know that it's a cause of sudden death, especially in young athletes. And so now we have specific screening guidelines that we do for sports physicals for pre-participation, because often sometimes it is picked up on a sports physical. So what I mean by misdiagnosis is sometimes we'll think that these particular individuals may have asthma, they might have mitral valve prolapse, they might have depression, and you might just hear an innocent murmur. Often they may be told that the reason they're getting short of breath with sports is that they may be developing sports-related asthma and that kind of stuff. So that's why we implemented some specific screening tools that help us determine or listen to the heart during performance of a sports physical. You can have a dilated cardiomyopathy, so you have ventricular enlargement. This enlargement again leads to poor pumping or poor ability for the heart to pump, and it creates heart failure in individuals. This generally leads to the need of having a heart transplant. But it can also be caused by exposure to toxins and infectious agents. So it's not always genetic, but in this case we're talking about the genetic form of dilated cardiomyopathy. We look at this when more than 2 or 3 family members have been affected by this. So we want to determine if it is familial. And it is a autosomal dominant primarily, but it can be autosomal recessive or X-linked recessive. So we need to understand which type of familial dilated cardiomyopathy an individual has. So we know that then there's a restrictive cardiomyopathy. This is the least common cardiomyopathy out there. So what happens is that when filling within diastole occurs, the ventricle becomes rigid, so it can't expand as it should to accommodate the flow. We see that these patients generally have a systolic function that is normal. We don't really know what causes this, often idiopathic, or it could be secondary to another disease that is occurring at that time, such as scleroderma or hemochromatosis. We know that it's not related to a specific single gene problem, but we do know that the gene coding happens on the troponin. And then we have arrhythmic right ventricular dysplasia cardiomyopathy. And it is puts people at higher risk for ventricular arrhythmias. This would be spontaneous ventricular tachycardia or ventricular fibrillation that occurs. Generally, the left ventricle is more involved than the right ventricle, and this can lead to sudden cardiac death. It does have some familial component. About 30% of individuals who die of sudden cardiac death have a family history of it. They are beginning to determine where the gene loci for this is, so that they can begin to understand what it does. And what it means about penetrance is incomplete. It means that the penetrance is variable. So not all people who appear to have these genetic components will develop this arrhythmic right ventricular cardiomyopathy. So it won't always present itself the same in every individual. That's the end of our lecture.